It's visible, right? Can we mute everybody other than Rishi?
Okay, can I start? Yeah, so good evening, everyone. So I'll start with the history of the patient. She is an 82-year-old female, previously no known comorbidity. Occupation-wise, she is a pujari and archika staying in the temple from couple of years. And she had only complaint of the dry cough since 2 years, which is on and off, and she is taking some medication for the dry cough. Next, ma'am. No previous particular medical history of hospitalization or any major illness, no significant medical history. Only history she had a chronic cough. For that, she is taking symptomatic management. I ordered couple of blood investigation. Hemoglobin total count, platelet count looks okay. Renal and liver SGPT-OT are normal. HbA1c was 6. Serum IgE only for cough I did was 356, and serum TSH was 4.30 was normal. RF factor, anti-CCP and serum ANA by IFF all comes to negative. Then I ordered the HRCT chest.
You're able to see, right, the CT?
Yes, ma'am.
Yeah. Yeah, so this is the HRCT, and here we see subpleural predominant reticulations, and mild early honeycombing is also there. There is a bit of movement artifacts, but even with that, we are able to see that. So it's definitely having a subpleural predominance and a little bit of basal predominance also. It's kind of little asymmetrical with right lung being slightly more severely involved, but both lungs are involved. There are no other lesions. She has also some mild bronchiectasis in the right lower lobe here, you can see. And just a second. She has a hiatus hernia, quite a big hiatus hernia is there. And there are calcifications around the aortic root, and the aortic root is mildly ectatic. So I would just do an echo to see whether there's any aortic stenosis or anything happening there. Yeah, and the main pulmonary artery is not dilated, no pulmonary hypertension. So overall, it is like an interstitial lung disease with the peripheral and lower lobe predominant. And because there's mild honeycombing, I would say like a UIP pattern.
Where is the honeycombing, Aparna? I couldn't really see that.
Yeah, there's like a lot of movement artifacts. So you can
okay.
see yeah, now.
Okay. Just a single layer there, right?
Yeah. There are a few layers,
okay.
like quite
Yeah,
a bit
now
of
it's better.
retic.
Now
Yeah,
it's
yeah. Now you can see. Yeah.
Okay.
We'll move to further slides. That's all, no?
Yes, yes, ma'am. I'll
There is
stop
another
sharing.
CT scan? No. For
No,
her,
no, single only, single.
Sure,
I'll
sure,
stop
sure.
sharing.
Okay.
So after that, I went through the PFT. It was FVC was 2.79 liter. DLCO was the 68% of predicted. I couldn't do the 6-minute walk test at that time. RV by TLC was 41.45, 90%. And we had done the echo also. It was mild PAH with the 44 of the PSP millimeters mercury, and EF was 60%. So this was the graph of the PFT and DLCO. So my question for the panel is that I was not sure about the whether it is the probable UIP. So as a patient is 82-year-old female and they working in temple only. In that scenario, is HP necessary for diagnosis confirmation, or should I start directly antifibrotic therapy? And when should immunomodulator or disease modifying agent should I consider? And she had a dry cough. Then what is the role of thalidomide and amitriptyline in this managing of chronic cough?
Sure. So I think we will start with Prahlad sir or whomsoever.
I
Like,
don't see Prabhu Desai, so I'll get going and Lakshmi can
Yeah.
follow me.
Hmm.
Uh,
Can you hear me?
Prahlad is administrator. Okay. Fine.
okay.
So the
Okay.
first question is
I-
whether the biopsy is required. I think not considering her age and more than that, there is a UIP pattern. I think I really don't want to do any biopsy. Okay, this is my feeling. And even second question is what?
I'll just share the screen. Yeah, I was thinking that so many, so we will
Okay,
forget.
can antifibrotic be started immediately? We can start antifibrotic, okay, but her cough has to be settled with small dose of Visalon or prednisolone, and we can taper it off over 2 to 3 weeks and see whether she responds to that or not, and then probably we can simultaneously introduce antifibrotic after assessing her liver function test, okay, and we should do see the tolerance to antifibrotic before continuing on long-term basis. Immunomodulators, I don't think so because this doesn't look like any at this age with all autoimmune markers also negative. And thalidomide and amitriptyline, I really never use for the cough point of view. So the cough will be in this condition can be well controlled for a tapering dose of steroids and maybe cough suppressant like a little higher dose of dextromethorphan in the syrup form or tablet form. If that is not getting controlled, then probably, and if the steroid shows any good response, I may minor dose of omnacotil or whatever it is I can keep to reduce the cough rather than adding sedatives to her like codeine's syrups. Unless she has got a nocturnal cough, then I can give her codeine's small dose,
Sure.
and that's if she is not constipation.
Okay.
So there are three things here. She's in addition to what Prabhu Desai said, Rushi, she's 82 years old, Rushi.
Yes, sir.
She's got a large hiatal hernia, and her fibrotic lung disease is more on the right than on the left. So there has been some data suggesting that unilateral fibrotic lung disease, more on the right than the left, can be due to aspiration. So if she has a hiatal hernia, 82 years old, I would think of aspiration-related ILD as a very strong possibility. And in which case you just need to do lifestyle measures and get an upper GI endoscopy done maybe and sort that part out. I agree with Prabhu Desai that in an 82-year-old with a UIP pattern, this pattern Aparna is going to sign off as typical UIP, then I would probably not do any biopsy here. I don't think it will help. And even if this is aspiration, if you prove aspiration on a biopsy with some foreign body giant cells, I don't think, I think lifestyle management endoscopy would help you with that part. And probably antifibrotics will make her worse if this is aspiration. That's the other thing. But it is tough. It is tough, at 82 to take a decision on histopathology here. Immunomodulators, certainly not. Thalidomide, amitriptyline. I mean, the fact that this question has been brought up, Rushi, that means her cough is one of the most important symptoms, right? In which case, I would start with an upper GI endoscopy and tell them that the antifibrotics are unlikely to help your cough, but we'll have to watch her lung function is very well preserved at 82.
Yes.
So I'm not sure about the urgency of an antifibrotic. Lakshmi, what are your thoughts?
Wondering whether we are dealing with something called CPFE in this patient because FEV1 is preserved and DLCO is impaired. There is pulmonary hypertension, but even on CT, there appears to be reasonably preserved lung volumes. Yeah, so FVC is 115% and DLCO is isolated decreased. RVTLC is also not favoring associated obstructive physiology, but I somehow am getting the sense that there's some amount of emphysema also contributing to it.
Anything on the scan
Maybe
to
trial of
suggest
bronchodilator.
that, Aparna?
No, not really. No, not really seeing any emphysema.
Okay.
Mild bronchiectasis is there, but no emphysema.
So maybe cough, we can see whether it improves with inhaled bronchodilators and see.
Aren't you giving that, Roshi?
Yeah, I'm not giving bronchodilator. Presently, I'm doing only cough management, and rest of thing I have not started yet. So
Mhm.
mostly next follow-up is next Monday. So probably I will
No
go for
harm.
it.
Yeah.
Yeah. Yeah. Okay.
And
Thank you
and
so much.
GI workup
I
as
would
Yeah,
I would
for
do an upper GI, yeah,
yeah.
and an inhaled bronchodilator trial before going to thalidomide and amitriptyline for sure.
Sure.
Yeah,
Yeah.
but if using thalidomide, make sure you use aspirin along because thalidomide can lead to thrombotic events. So whenever you are giving thalidomide for any indication, you need
Yeah.
to give aspirin along.
Prakhar, are you ready?
Thank you so much.
Prakhar?
Yes, ma'am. I'm ready.
Okay. Sure. So second case is from AIIMS Rishikesh. Dr. Prakhar will be presenting.
Ma'am, regarding the previous case, can I ask a question? I have put it in the chat box as well.
Oh.
So as a
Related to ERDS.
yeah,
We were just discussing that.
Yes, sir.
As very likely. In fact, I was just saying there was a series from the UK where they reported unilateral ILD in patients with reflux,
Yeah.
And so, this is more on the right side. She has a hiatal hernia. So certainly worth doing an upper GI and treating for reflux aggressively.
Yeah. Go ahead.
So beginning with my case, she is a 71-year-old female who is a housemaker and a non-smoker. She had been hypertensive for 4 years, for which she was receiving telmisartan and amlodipine. She presented to us with symptoms since last 4 years of breathlessness and cough, which was predominantly dry. Recently, she had developed bilateral lower limb swelling since last 3 months. There were no CTD symptoms and no systemic symptoms per se, which could direct us towards any connective tissue disease. Going into the history, she had dyspnea since 4 years, which gradually incremented from grade 1 to grade 4, dry cough, which was present since 2 years. We evaluated the case and diagnosed her as a case of ILD fibrotic HP with a moderate confidence based on her symptoms, mold exposure, HP panel being positive, and HRCT suggestive of triple density, as we discussed in the radiology part. PFT was suggestive of restrictive anomaly with FVC of 57%, 6-minute walk distance of 251 with a desaturation of 6%, and her 2D echo was normal, no pulmonary hypertension was. So we were under our trial. So under this trial, she received steroid plus mycophenolate mifetil with a tapering dose of steroid and from 50 mg OD and then gradually towards a 5 mg alternate day. And MMF, which was started as 500 BD, was picked up to 1 gram BD. So while on treatment since last 1 year approximately, the patient was compliant and her cough had improved and dyspnea was slightly variable. She slightly improved to grade 2 and at times was complaining of grade 3. Now, the things started changing in January 25, approximately a year after the therapy of immunosuppressants, when she developed an infective exacerbation, was detected with MRSA pneumonia, and was managed symptomatically. During that time, steroid MMF were discontinued, and the patient, that's it. Then again in February 25, around a month later, she developed features of right heart failure with swelling all over the body suddenly. During this admission, she underwent an HRCT again, which revealed GGOs, consolidations, and worsening fibrosis. A 2D echo was done, which revealed mild pulmonary hypertension, and the patient was started on prednisolone MMF, which had been stopped previously in the infective exacerbation, and this time nintedanib was initiated. In March 25, again this patient developed another infective exacerbation. This time, blood culture revealed E. coli. However, it was not very, we were not very confident, but there were certain signs and symptoms. So again, immunosuppressive therapy was discontinued while nintedanib was continued, and a 2D echo revealed moderate pulmonary hypertension this time. So over a month, from mild to moderate pulmonary hypertension. These are of the last admission, that is March 25, when she had a SpO2 of 98%, a rate of 24 breaths per minute, and the rest of the vitals were stable, and examination revealed just crepitations, no wheezing. Again, these were of the March 25 admission. CBC was normal, TLC was slightly higher, suggestive of infective. CRP was high, of course, 66, and 2D echo, as we told, revealed a moderate pulmonary hypertension. This is from December 23 to May 24. That is just about 6 months of therapy of immunosuppressive, where she was receiving steroid along with MMF. And at the baseline, she had a restrictive anomaly with the FEV1 FPC of 46% both. 3 months later, FEV1 by FPC improved to 84. FEV1 FPC again improved to 63%. 3 months again, or 2 months later, this was a little dubious for us, as her FEV1 suddenly picked up to 106. This FEV1 FPC in May 24, I apologize, it's a typographical error. It was 87% or 89%, not 54%, of course. FPC was again 57%. So FPC picked up in 3 months, then slight deterioration to 3% by 3%. 6-minute walk distance as well showed that the distance walked deteriorated from 251 to 179 and then picked up to 249, reaching the baseline. And the desaturation was 3% initially. However, it was significant to 10% later on. After May 24, we could not get any PFTs as the patient was unable to do that. And if we can discuss her radiology of the baseline and the February 25.
This is the CT from November 2023. We don't have the full upper lobes. It's kind of starting a little bit below. And we see the, like you described, the triple density sign is there, and there's a lot of reticulations, a lot of ground glass opacities. This lobular kind of areas of sparing and air trapping is there. We don't have expiratory, but it looks like air trapping on this. And in the lower lobes, there is architectural distortion with traction bronchiectasis. Minimal early honeycombing is there. So it is looking like a fibrotic hypersensitivity pneumonitis at this point. Sorry.
At this point, we wanted to do a BAL for this patient, but the sheet hadn't approved for it.
There were some small, mildly calcified lymph nodes, which are looking enlarged, plus they're hyperdense and mildly calcified. Pulmonary artery was not dilated at that time in November 2023. The next CT that I have, I'm not sure that actually belongs to this patient or not. The name is the same, but there's
No,
is this some other patient, because there's a huge goiter.
Yeah, no, ma'am, this is the
Must be some other
other patient.
patient,
Yes,
is it?
ma'am.
Okay, so then I don't have the present CT, sorry.
So the Asmita, ma'am, how can we see the recent CT?
Yeah, it is
And-
very confusing.
Okay,
If
yes,
we are
ma'am.
sending 2-3 CT scans and all. Now, I actually tried my best to explain to
Definitely,
Aparna. Yeah,
understand.
okay, but we have to bear with that. It's okay.
Okay, okay.
Mm.
So
Oh, I downloaded it, but it looks like a different patient. There is a recent, like March 2025 CT, but like I showed you, there's a patient with the huge goiter, which
No, ma'am.
I'm
So
presuming it's some other patient,
some other
but the
patient,
name
yes.
was same, but maybe you sent a wrong CT. That's what I'm trying to say.
Yes,
That
ma'am, I
name
understand.
was same. Mm.
So in the latest CT, what happened was that both the bases, as we were able to see a lot of air trapping in the previous CT around a year back, now this was entirely a dense consolidation. And if I can see, okay. Asmita ma'am,
Hmm.
is it possible that I can share my screen? No, I think
Yeah,
not.
you share no problem if you
Okay,
have
I'm
images.
trying
You
if I
sure?
can.
Yeah, you share the screen. No
No,
issues.
ma'am. Am I visible, ma'am?
1 second. Yeah, coming.
Okay. So we all can see the CT now.
Mm-hmm.
Okay. So this is the present CT of February 25. Aparna ma'am, if it is possible,
Yeah,
for you
yeah,
to
yeah. I'm
compare it
seeing
with
it.
the
Yeah,
previous
I'm
one.
able to see.
And please
Yeah.
tell me where to stop.
Yeah, so definitely the ground glass has increased, and especially more in the lower lobes. There's significant increase in ground glass. Some of it is much more dense and becoming like consolidations. And it's a little difficult, but I think the fibrosis has not particularly worsened. It's almost similar, maybe. It's just that we are able to see those small cysts more better because of the superadded consolidation.
Okay.
Still we are seeing all these some areas of that like air trapping, those lobular areas of air trapping and sparing is there. So I think definitely there is some worsening, which, like you said, with all the CRP and counts raised, whether it's like an superadded infection or some kind of acute exacerbation of this ILD itself.
Yes, ma'am. At this point of exacerbation, she had a right heart failure symptoms, but no features of infection per se. And by our eyeballing, what we could see was that there were some additional areas of fibrosis and traction bronchiectasis compared to the previous one of November 23.
Hmm.
So I'll stop sharing my screen, ma'am, then.
I'll share your questions.
Okay.
Yep.
Over to you, ma'am.
Yeah.
So in summary, okay. So my question to the panelists that can we call this as a progressive fibrotic HP? And since we had already given this patient quite a lot of immunosuppression, now she's having certain complications related to it as well in form of infections. What would be our possible treatment options now in this patient? Shall we use some other immunosuppressive agent while taking the risk that she's already having infections and so on? Antifibrotic, of course, we added, but how do we see this patient to be going ahead with, and what additional can we do for this patient?
And
Hey.
Prakash, she's always been on dual immunosuppression, right? Prednisolone and mycophenolate, correct?
Yes, correct.
Okay. Yeah.
Mithun, are you there?
Yes, I'm there.
Yeah, Mithun, this lady was receiving 1 gram BD. So if your patient is developing recurrent infection, what dose you would continue if patient is like
What was the steroid dose?
what was
So
the
it
steroid dose?
started at 50 mg OD. It was approximately 0.75 mg per kg for her. And she was under a trial, over a year, we had dropped down her to 5 mg alternate day dosing by week 52.
Most of the time, steroids may be the culprit. But mycophenolate, some people after 6 months, most of the time we reduce to 500 milligram BD, total of 1 gram per day. But this is as per the trial dosing, no?
Yeah.
Yes.
Okay.
Moreover, what we see is a lot of dense consolidation. And at that point of time, of course, we could not find any features of infection. So we were not attributing it to the infection per se.
No, can I talk?
Yeah.
See, whatever I could understand, she has a recurrent lower respiratory tract infection. Okay, as the history point of view, the HRCT, she was on very good dose of immunosuppressants, which is really can be used in the hypersensitive pneumonia. In fact, I find it is little higher only,
Mhm.
but whatever it is, is the trial case, so that dose. And HRCT shows alveolitis. So this is I observed is a lot of patients they have big infections which are not generally seen on routine examination, and this patient require bronchoalveolar lavage. Okay, and these patients we can detect in a pneumonia panel many viruses. We have seen a cytomegalovirus is a very common culprit which presents with breathlessness, worsening of radiological shadows, maybe fever and other thing. Even similarly, PCP pneumonia also we should think about. And before we consider any immunosuppression or stepping up steroids, it's mandatory that we should not miss any other infection. Not the bacterial, I'm talking about other infections, which are also pretty common with immunosuppressants, including
Okay.
influenza also.
Yep. Lakshmikant.
Nothing much, ma'am. CMV,
Okay.
PCP, we'll have to see, and maybe we'll have to go a little higher on the dose of steroids because the radiology is showing more of alveolitis than infective worsening. So none of the shadows on the subsequent CT are showing that of infective worsening. So bacteria, if found, they can be treated shortly. But problem is that holding mycophenolate, I would like to sort of get hang of that. Do we really need to hold back the
I think so.
mycophenolate whenever we have infection? Because its action actually takes about weeks to build up and then weeks to go by. So by the time what you are actually seeing is infection is getting under control and the immunosuppression also is going away. So the disease comes back again. You are under constant threat of infection. You are thinking it is infection, but it is actually the disease which is coming up. Secondly, holding back steroids completely for somebody who is on maintenance dose of steroids. So whenever you are dealing with infection, it is sort of mandatory to put them on at least stress dose of steroids rather than taking them off completely. Otherwise, they may end up with adrenal crisis.
I think CTD ILD when they get infection and hypersensitive pneumonia when they get infection, the behavior of the lung is much different. CTD ILD, I understand if you are reduced the immunosuppression, probably the disease may get worsened, but this is not the case in hypersensitive pneumonia. I think infection is the most likely cause for worsening the patient's status. So there's no worry in stopping mycophenolate, I feel.
Cumulative dose, I suppose, must be acting. But she has received a lot of over a year of immunosuppression. So that entire effect shouldn't wean off just in about a week or two.
Yeah.
Possibly it should continue its effect. And by that time, we had already reintroduced her towards the immunosuppressant. But the question is, I understand that because she is immunosuppressed due to the disease as well as because of the drugs that she is receiving, so she might not produce the same clinical signs symptoms of an infection as a normal person should. But still, the amount of consolidation and the ear trapping has definitely seems to have increased. Of course, if we attribute it to infection, antibiotics or the other antivirals, etc., usually always given, and but then the patient's clinical symptoms and everything should revert back slightly towards the previous state. Now, this patient having this CT after a year of lot of heavy immunosuppression. I understand we do not again have sequential FVCs or DLCO to call her as a case of progressive fibrotic HP yet, but just based on her symptomatology, considering recurrent exacerbations as a manifest of progression of disease, and based on the CT radiology, can we still think in terms of that this is progressive despite this immunosuppression?
Should we repeat a CT in an interim period where she is not having these acute symptoms and see whether that actual, I'm not very sure of that actual progression of the fibrosis. Like the predominant thing now is the ground glass and consolidation. Maybe there is some progression, but it's difficult to actually say when so much other changes are there. So when she's coming back to that baseline, can we repeat and see whether actually there is worsening in fibrosis?
Okay, that we can try, ma'am, definitely. I'll try to get it done.
But to get her back to baseline, what exactly are you doing, Prakhar?
That's my question, sir. What
Yeah,
can we
that's
do to bring her to the baseline?
exactly. So, like Prahlad said, chronic CMV infection, PCP, I think it would be worthwhile. Is she fit for a bronch, diagnostic bronch?
We may attempt to do that, sir.
I think if you do that, you will get infection out of the way. And then, as Lakshmi said, you could get the bronch done, then treat her empirically with what you think is appropriate with pushing up the steroid dose. And then maybe even if you have PCP, CMV out of the way, a gene expert for TB out of the way, I think you could even pulse her for a few days, maybe not a very high dose, then repeat the scan, as Aparna is saying, because otherwise you wouldn't have done enough to treat potentially reversible things. What do you feel?
Sure, sir.
Yeah. So the basic disease I feel is not yet under control, especially with the lower dose of steroids.
Yep.
So shall we increment the dose of steroid again?
We can.
I think
And
after
for CME, you need not do BAL also. You can just do quantitative PCR on blood and see whether there is CMV viremia. If it is there, and especially if it is going up sequentially, you know that it is because of CMV. And CMV can very well look like any other ILD, especially with the background of interstitial lung disease.
Yes.
Okay.
Okay.
Okay. Thank you, sir.
Thank you,
Thank you,
Prakhar. We will move on to the third case. Third case is Miss L, right? That's what we discussed, Aparna, right?
Yes.
Yeah, okay. So I will move on to the third case. That is our case from Amrita Hospital. She is a 53 years old lady who was referred to me from my colleague from Todula, and she is a homemaker, business of pickles and flour. Now she has rheumatoid arthritis, and she had all the features of hand features, and she has nodules and everything. But she is telling that her rheumatoid arthritis was well controlled till last few months, and she has history of asthma, allergic rhinitis kind of thing. Now before 4 months, she started having low grade kind of fever kind of feeling in the night, presented with joint pain in inframammary and area and back of chest, as well as low back pain in finger joints, stiffness of joints, which is suddenly started increasing, and associated shortness of breath. However, her spirometry, everything was normal, but she complained of grade 2 dyspnea. Whenever she was working, she was not able to carry out the activities which she was earlier able to do. There was some amount of weight loss also. Because of that only, she presented to my colleague. When I examined, her saturation was 100% on room air. Her every parameter was normal. There were no chest signs of any ILD. She didn't have any CTD stigmata other than rheumatoid arthritis changes on the hand. Her blood investigations were fairly normal, including RF factor was negative, but maybe she has seronegative arthritis. I'm not sure why that was negative. And we did a CT scan chest. This is outside CT, not from Amrita.
So this is a CT done on 5th of March. So on the mediastinal window, we see multiple nodes are there, right paratracheal, subcarinal, bilateral hilar, quite a bit of nodes are there which are significant looking. And I'll just go to the lung window. So this is the lung window, and one thing is there's lot of inhomogeneous attenuation. So there could be some amount of background obstructive airways disease, some little bit of post-inflammatory changes, some scarring, traction bronchiectasis, focally is also there. In addition, we are seeing multiple nodules. So some of them are like irregular like this. Some of them are more smooth. Many of them are periphyseal or subpleural in location. And in the upper lobes, they're even more like irregular and having some tiny nodules adjacent to them also. Just zoom it a little bit. Yeah. So the initial thought that came to my mind before I heard all your history was I was thinking between sarcoid and TB because of the lymphadenopathy and these kind of irregular nodules, plus there was some post-inflammatory changes. Now thinking with the rheumatoid, I'm trying to put together the rheumatoid. So I am not really seeing any ILD related to rheumatoid. It's just the nodules. So whether it could still be rheumatoid nodules, that is one possibility. And lymph nodes, we do see often with many of these connective tissue disorders, just a reactive lymphadenopathy. But I think this is quite, I mean, little bigger than
big,
what we
quite big,
usually
yeah.
see. And we usually see quite a big bit of nodes in the axilla, which we were not seeing in this patient in CTDs. So I'm still having that
Your
doubt about
differentials are
sarcoid.
sarcoid bar TB, right?
Yes, yes.
Okay. So I'll move on
But
to
that was her differential if she didn't know the diagnosis of RA.
Yes.
yes. So that is good, na, sir? Because
So the moment you get RA in the differential, you have to first, we need to know, Asmita, the drug list. What is she on?
No, she is not on any other than HCQ. She didn't receive anything, and presently she was not on any drugs. She went for some Ayurvedic treatment, and she is telling this, it's well controlled, no problem at all. And just for last 3-4 months, this happened. So when she came to me, she was not on any medicines, and that also I inquired. She told it was well treated. She went to this doctor, that like Ayurvedic, homeopathic, all those kind of things. She's
Basically,
fine.
no allopathic treatment.
No.
Basically,
She's happy. Yeah.
Then likely it is not RA.
Yeah, she is
Yeah.
so happy about it that it's so well. This thing is fine, and I was like, fine, chalo. Okay, Aparna, if you will
Yeah, do
stop
we
sharing.
have like hand X-rays and all which is looking like RA, or
I
can like sometimes sarcoid people also have the arthralgias, right? Could it be
yeah,
sarcoid
but I
related?
no, I think she had that Swan's deformity, and maybe there was that post proximal distal interphalangeal joint. That
Bottom
Okay.
yeah, all
Okay.
those classical RA changes. Yeah, I know.
Anti CCP?
I didn't send.
Okay.
I'll
Okay.
send that next time
So
because I was
rheumatologist hasn't yet seen her, Asmita. No rheumatologist has seen her.
no.
Okay.
Okay. I'll just see anti-CCP. Maybe we have done or not. Let me see. We'll share the screen once more. No, anti-CCP I didn't do, Mithun. These are all done from outside. I did RA factor only. So we went ahead with EBUS, and as Saparna said, there were multiple lymph nodes, all big nodes, and all were like hypoechoic kind of I won't say necrotic, but it were all hypoechoic node. And if Ritu madam is there, we would like her wisdom over here. So we didn't get much on the rows, but finally the report came as this. So what do you say, Ritu madam? Are you talking?
Ritu is muted.
Hello.
Yeah.
We can hear you.
Yeah. So the FNA smears which we are seeing, which are stained with the Giemsa stain and the PAP stain, are showing very well formed non-caseating epithelioid cell granulomas. And so this is the next. So this is a Giemsa stain and this is the PAP stain. And in this also, second smear also, we are seeing very well-formed non-caseating epithelioid granulomas which are there. So this is actually two images which are available on the FNA which was obtained. And the third image also showing the same granulomas and granulomatous inflammation which can be seen. So with this, actually, we need a biopsy and further to see whether we are keeping the differential diagnosis of sarcoid, tuberculosis, and RA. We would need further investigations and AFB stain. I don't know whether it was performed in this.
We did
smear
negative. All
or
ancillary
was
tests for tuberculosis are negative.
were negative.
Yes,
Okay,
yes.
so beyond this, on this smear, it'll be difficult to comment. Only my diagnosis here would be a well-defined granulomatous inflammation as of now, and then asked for biopsy and to put up special stains, like as I like to put up CD4 and CD8 to differentiate between sarcoid and tuberculosis, because again we can see non-caseating granulomas even in tubercular patients also. So this is where we would stand after histopathology.
Okay.
One doubt, ma'am. How you can differentiate between sarcoidosis and TB in biopsy?
So we are running some preliminary studies done around some 40-50 cases now. And the CD4, so basically we'll have to correlate all of them together. But the CD4 expression and the CD8 expression, whether they diffuse or whether they are in the peripheral of the granuloma, is one additional point as compared to the presence or absence of the necrosis and the presence or absence of the morphology of the Langhans type of giant cell, which we can add to one of those features of whether it is going towards tuberculosis or sarcoidosis. It's not definitely conclusive, but it is one of the features which can be added to the diagnosis.
But it cannot be done on cytology slides. You need biopsy slides. That's what you are saying, huh? If we have cell block
No,
and all.
we can do it on cytology.
You can do it
So
on
if
cell
we,
block here.
yeah, actually we do it on cytology, but on cytology, then we need to first prepare the smear for some 8 or 10 days with fixing it in a special way, and then run it through IHC. So that also works, but again the procedure itself is 10 days long.
Sure.
So that's yeah.
But if these blocks are sent to you, Ritu,
Right.
and you do a CD68 and a von Cossa stain, pan-CK, you can do it on that?
Yes, we can. Yeah.
And that would also help you, right? To answer Mithun's question?
Yes. If I'm seeing the Schaumann body, in some of the cases, what we've seen is that if the Schaumann body is present, which is the lamellated calcification, then in that case, performing the von Cossa staining and showing the positivity is pointing out towards sarcoid. So that is another of the 5, 6, and even like the reticulin stain.
Yeah.
So the multiple kind of indicators towards one or the other disease. Yes.
I know you've done it for me before. That's why I brought it up.
Yeah, interesting. Actually, TB and sarcoid, we say pathologist will write clinician's discretion is required. That's what my pathologist does anyway. So we discreet, no problem. Yeah. So yeah. So my questions to the panel is like as Aparna brought out that whether rheumatoid arthritis can cause this, but rheumatoid arthritis causing granulomatous inflammation. Mithun, do you agree for that? And
in this case, the basic diagnosis of rheumatoid arthritis may be the doubtful.
Yeah. So I also build, and then she has only, now my real question was, she has only mild dyspnea and joint pain. Her spirometry was well preserved, though I don't have put the table over here. Do we need to treat such sarcoidosis? And what makes you decide treatment in any sarcoid patient with preserved lung function and no parenchyma? Like she had this nodule involvement, but whether we should really treat her? And if yes, her main complaint was joint pain. So should we start steroid or should we start methotrexate?
So I'll let Lakshmi and Prahlad also go, but I have only one thing here. If her lung function was normal and assuming her DLCO was at least more than 50%
DLCO
predicted.
was not done, sir, actually. Yeah,
Yeah,
but it will be. Yeah, it should be.
I
Yeah.
would imagine it's more
Yeah.
than 50% predicted. Then
Yes, sir.
we wouldn't treat. But you said mild dyspnea and joint pains. I would be happy to go with HCQS or methotrexate, but I'd defer to Mithun on that. I think he may have a personal preference there because I'm not treating the lung here. I'm probably treating the joint. And so methotrexate, now we have some data that you could use it upfront as the only drug here, or maybe HCQS. Lakshmi, Prahlad?
Yeah, this is, whatever the histopathology I understand, this.
And also we are assuming, Asmita, your TB cultures are negative, right?
Yes, we have.
Prahlad has gone off. Lakshmi, you want to say anything?
Granuloma is not looking like an angry granuloma of TB. This is 100% looks like an nodularity. Okay,
Yeah.
so it looks like a sarcoid and
Yes.
hardly any symptoms has. So if there's no unlikely to have end organ damage, we should not be very aggressive. We should be observant. And symptomatic treatment, as you rightly pointed out, arthritis is predominantly manifesting, then probably hydroxychloroquine is a good drug. It works very well in sarcoid. Cough is a manifestation, and probably may put her on inhaled steroids and see. And let's observe rather than put our foot into it. Because once you start methotrexate, then you will not be able to come out of it so fast. And again, steroids is the same. So why not observe a little more?
Yeah.
I would, Lakshmi, anything?
Yeah, Mantu. What is Mantu?
Mantu was negative.
Mantu negative.
Done twice because they also did, I also did. Negative.
Then we can decide to observe, or maybe just give hydroxychloroquine and see whether the musculoskeletal symptoms get better, and observe for lung functional assessment, maybe 3 monthly.
So my problem was yes,
Yeah.
Mithun, go ahead.
I think before treating any joint pains, it can be very non-specific. If it is arthritis, it's correct that you can use hydroxychloroquine or methotrexate. But sometimes patient may say joint pain, but it may not be. It may be osteoarthritis, some other issues. And if CRPs are normal in this case, no?
Yes, CRPs are normal. Not high. Not high. Nothing. No inflammatory markers high.
You need a detailed examination before deciding on
I'll
any.
send her next time when she comes. She recently came for viral exacerbation also. So otherwise she wanted to continue with the regular doctor. The problem was those nodules which are seen on the CT scan. Like, can we take it? How do you stage this sarcoid, Aparna? If there is a lymph node and there are lung parenchymal nodules, you will label it as a stage 2 sarcoid.
Yeah, I think there is definitely some involvement of lungs. It's not like
so
lungs
it's
are
not
normal.
stage 1. Yeah, that
No,
is why my
it's-
worry is not only the joint pain. We have got nodules in the lungs, and like if I leave it alone, will it increase in the size and become? I don't know. That is why the discussion was basically for those. Yeah.
Even if it's stage 2 and even larger nodules in the lung, you don't need to treat if the patient is asymptomatic with normal lung function.
Sure.
So I would say you could.
But best is to actually go ahead with the ophthal examination, calcium, urinary calcium, try to find out that.
So I think till you get a rheumatologist and a little more workup, I think we'd call it sarcoid moderate level of confidence, right?
Yes.
Yeah.
No, I think serum calcium and all I did. It was not high. ACE was 49. Manto was negative. Urine calcium I didn't do. Eye examination I will recommend. Yep. She didn't have symptoms.
If the 6-week culture is negative for TB, I think the
sarcoid is
almost moderate to high confidence here in sarcoid.
Yes. We will move ahead to the next case, which is also equally interesting. So this is this is a doctor who was working in a neurology section, and he came to me because he had dry cough. He is 48 years post-COVID, history of dust allergy, food allergy, nothing significant. Came to our hospital for clearance for trip to Australia when an incidental finding there was a calcification, and then he went back to his hospital and did a CT scan. Now that particular CT scan, he was found to have some right lower lobe consolidation, which was not resolving. The radiologist made a diagnosis of organizing pneumonia. The treating doctor started him on little bit of steroids. The cough subsided, but the repeat CT scan chest was still showing it persistent. After 1 month, he came to me. So this is a third CT scan which was done in my hospital. Second opinion from our radiologist for the outside CT scan was, they told that, okay, this can be organizing pneumonia, but it has to be followed up. And that is how we followed it up. Patient has normal vitals, nothing significant. This was his spirometry and lung function when he came to me, as you can see, very well preserved. His main concern was why that particular shadow is not going anywhere. Aparna, if you can show the CT. Yeah.
Yeah. So this CT is done on 24th February. So
Yeah.
this is at what point?
I don't have outside CT. This is our hospital CT
This
only.
is
Yeah.
after a course of steroids.
Steroids, yes, 1 month.
Okay.
Yeah.
Okay.
How old is he, Asmita?
45.
45. Okay.
So there is this area of consolidation in the right lower lobe, peripherally, and it's like touching the pleural surface. The rest of the lungs, I think he has just had a biopsy just before the CT, CT guided biopsy. So there is a pneumothorax. I'm presuming that is related to the previous biopsy.
Yeah.
And there are a lot of areas of atelectasis, and there is just this one calcified, one calcified nodule here in the right lower lobe, with some surrounding that also a little bit of consolidation is there, and a lot of areas of atelectasis. He does not have any significant lymph nodes, and pulmonary artery is not dilated. He is having some mild coronary calcifications. So that is those are the main findings. So basically, it's just an area of consolidation, which if it is non-resolving, and it is a peripheral area of consolidation. So and the previous one was in the same area, right? It's not a fleeting opacity.
No.
It's the same
It
consolidation.
is there only. That is what they made a diagnosis of organizing pneumonia because it was just there, and their biopsy came inconclusive. There were some prone cuts. Did you get it, Aparna?
Yeah, I think there are some.
Yeah, that was
the part of the biopsy. I think that was
yeah.
this
Those,
one.
if you can, just change it to lung window, because there was some. Actually, the radiologist reported one layer of this fibrosis, and that is why he came to me telling that is it interstitial lung disease or kind of, because there was only one single layer of some cyst or something which was reported by them. So there was a doubt of some early ILA, interstitial lung abnormalities or something, and then whether this is a part of it or not. Yeah.
No, I mean, I don't want to label it as any ILD, because whatever this little bit of fibrosis is very focal, and it is just next to this calcified granuloma and just near it. I think it's just some post-inflammatory change. I don't think we should label it any ILD.
Okay, it is not. Yeah.
Yeah.
Okay.
And no eosinophilia also, right? So
No. He was
vasculitis workup is other thing whether we should do. Mainly it's a peripheral consolidation. So those are the things.
that ground glassing which is next to it is looking like
because
hemorrhage
of biopsy. Yeah. Biopsy.
Hemorrhage of biopsy. Okay, fine. But calcification is there in the lesion as well as the outside lung also, other than that, right?
Other lung also. He must have had some old TB, something.
Sure. Yeah. Okay. So so one of the differential diagnosis which was told to us by both the radiologists, both two different radiologists suggested was this can be BSc. And then we did a PET CT, but I don't have PET CT images. PET CT also didn't show increased uptake or anything, but we wanted to chase it because he is a doctor. He was really worried about two different radiologists telling that it can be bronchoalveolar carcinoma. And you all had seen the amount of consolidation. It is hardly 1/2 centimeter of area of consolidation from where we did CT guided biopsy. And this was the report of that particular specimen. Ritu madam, if you are there.
Yes. So in this section, which we can see on the left-hand side, there is lipidic carcinoma, And the lepidic carcinoma is extending across, it is characteristically as mentioned, it arises abruptly from the normal alveolar wall spaces, and then it extends along the alveolar wall. So towards the left-hand side with the yellow arrow, you can see the lepidic carcinoma, which is extending along the alveolar spaces. And to the right-hand side, the blue arrow is the normal lung, which is there. But there is on the right hand side of the image is the higher power of the same, where we can see the acinar the structure of the carcinoma cells, which are arranged in acinar pattern. And higher power here, you can see that there are some which are mucin secreting cells, and some which are non-mucin secreting cells. But there's one thing which you can see in the previous image, and that is that it's not only a lepidic adenocarcinoma, but in addition to the lepidic adenocarcinoma, above the blue arrow, there are the tumors glands which are invading from the main tumor into the surrounding periphery. So this is the latest classification of lung cancer, the WHO 2021, which says that in addition to the size of the cancer, you have to also measure the tumor cells which are spreading through the air spaces. So here I have a feeling that here if we see it under higher power and we count the area of how the tumor is spreading through the air spaces, and then we grade this tumor into the lepidic adenocarcinoma predominant with 20% or more. We'll have to measure the actual tumor which is there in the biopsy and see whether it is 20% or less than 20%, and then categorize it into high, moderate grade or low grade adenocarcinoma. So my diagnosis here would be an invasive mucinous, part lepidic, part mucinous adenocarcinoma. So that's how it will go.
Yeah, so the reason is like the reason I have put this case is we come across many persistent consolidation and many ground glass opacities which is labeled as organizing pneumonia, and many times we shy away from doing biopsy. So when to observe and when to do biopsy, that I think Aparna can guide us. And are there any red flags that warrant early tissue diagnosis that mostly my clinicians can take?
I think any non-resolving has to be biopsied definitely, because if it was OP, it should have responded to the steroids. No, if it's
Yeah.
not responding, I think I mean, there's no specific thing that only these. Even PET can be negative because
Yes.
early adenocarcinomas can be negative on PET. So PET may not be the deciding factor. Non-resolving has to be biopsied.
Anything, because this was a very small consolidation and it was just I don't know. We decided that because two different radiologists told the same diagnosis, it is better we go ahead with that. So, and the second question was, do we find anything, Prahlad sir or anybody wants to point that when will you consider that okay, this is not done, other than steroid responsiveness? There was nothing in this patient which would have helped me to go ahead with biopsy other than he was a doctor and I should over investigate.
No, I think biopsy, like Aparna said, non-resolving pneumonia, Asmita needs a biopsy period. It just depends if the patient has a strong view, very elderly patient doesn't want a biopsy.
Okay.
That's a separate situation, but these patients need a biopsy.
No, here there is a problem because the patient underwent one biopsy inconclusive, PET-CT negative. So to convince such patients for undergoing biopsy, sometimes it's difficult. Otherwise, I would have definitely, I agree with you, I would have just went ahead with lobectomy. I told even before undergoing biopsy that if it comes inconclusive, no point of following it up further, we should take it out, because something has to be taken out. So I also totally agree, but is there anything like we should be doing properly? That's it.
So,
okay.
Inconclusive biopsy, I think yes, a repeat biopsy is required. I mean, in such cases. Prahlad, you were saying something?
Yeah, I think any case of organizing pneumonia, this is what actually sometime I heard somebody. Any case of organizing pneumonia, if there's no previous history of any infection which is there, okay, previous history of an infection, then that organizing pneumonia on radiological diagnosis should not be considered organizing pneumonia unless you investigate a patient thoroughly. So which including autoimmune markers, drug history, And there's always a differential diagnosis of eosinophilic pneumonia when you do a biopsy.
Sure.
And also, we always get a diagnosis of eosinophilic pneumonia, organizing pneumonia with or a malignancy. Even tuberculosis also can sometimes have an organizing pneumonia pattern.
Sure.
So we should always biopsy.
Yeah. I think that's the message, that you should always biopsy any organizing pneumonia and any non-resolving pneumonia, as Rajan said, told period.
And do you think that
Yes.
the treatment changes, Ritu, from this more than 20% and less than 20%? I know we don't have an oncologist today, but would that change significantly?
Yes, I think because the recent classification is mentioning that even with the staging and the spread through the alveolar spaces, because here we are seeing two components. So I
Right.
think the stage and the grade is going to change in this patient.
Sure.
Okay. But if we are doing lobectomy, it should not make much difference, right?
No, there must be a reason that the
They have
ANM,
put the staging.
yeah,
Okay.
they put that
Yeah.
staging, either
Yeah.
prognosis or something must be.
Yeah, because it's going from, if it was only lepidic lepidic with an invasive component, so the staging is going to, the grading and the staging both are changing.
Next
Okay.
time we get this pathology, we should get a med-onc just to educate us sometimes, I
Yeah,
feel.
definitely.
It's
It's interesting. Yeah, maybe I'll ask my oncologist. Your case, Rajan sir.
So this is the last case.
Yeah,
31 guy. He's a young guy working in financial services in Mumbai. Never smoker. He's got one child. He had a history in the past of thyroiditis, December 21. And a routine check, he was diagnosed with lung cysts. He did one of these fancy routine checks where they do CT scans, and I think they showed up some cysts. And he was asymptomatic lung-wise, just a tendency to catch colds more easily in the last 3 years. No autoimmune or Zika symptoms. Played regular football till 2023. Now does yoga 3 times a week. Also in the history, interestingly, as pigeon droppings, feathers on the terrace, he does yoga there on the terrace, which he has been advised to stop doing it in that location. AC pipes leaking at home. There's also blackness on the wooden panels of the AC. There's mold in the bathroom. Prior to 2023, now cleaned. His autoimmune panels, as you can see here, were largely negative. VEGF-D was normal, which we can do because of the ICMR lab we work with. And the HP panel was strongly positive. And you can see these were the antigens that were positive. These were all positive. Parrot, pigeon feathers, this. So next slide. He had a routine lung function done in 2022 because his rheumatoid factor was positive. And so he did a lung function, but the rheumatology review then was negative. Nail fold capillaroscopy was also done, negative. Schirmer's negative. An ultrasound parotid done a month ago showed hilar echoes were maintained, salivary glands were normal, few reactive nodes. And his lung function, as I said, he did a routine test in 22. That's what his vital capacity was. The DLCO 60%, and in Feb 25, a slight drop from October 22. And that's where we are. That's his lung function. And Aparna could bring up the images if possible.
Yeah.
So these are a CT from February 2025. So first thing we see is like diffusely the ground lungs are abnormal, like a diffuse ground glass densities are there. And if you look closely, it's almost looking like faint central lobular nodules are there diffusely, plus a diffuse increase in the lung attenuation. And there are multiple these thin walled cysts which are scattered everywhere. Some are along close to the pleura, some are close to some vessels, could be like perivascular. Some of them have some thin septations within them also. So that is the main findings that we are seeing. There is no pneumothorax, and there was no significant lymph nodes. Pulmonary artery was also not dilated. So that is those are the findings. So if we consider all his pigeon droppings and if we consider all these to be faint central lobular nodules, hypersensitivity pneumonitis is definitely one thing that we will think of, and we know that we can get some cysts in HP, but I think these are too discrete and too many. Like we can get few small cysts, but these are looking too many for that. So the other thing, because of the diffuse abnormality in the lungs, diffuse ground glass, whether it could be a LIP, lymphocytic interstitial pneumonia. So whether we should do workup for, you said the parotid ultrasound was normal, but whether we
Yeah.
should do any other workup, I don't know, lip biopsy, etc., for Sjogren's.
Yeah, I think he was advised a lip biopsy that time or not. I cannot recollect. But I don't think he was advised a lip biopsy that time. He had just got that workup done.
Yeah.
And
And I think there's a small percentage of idiopathic LIP also, right?
yeah,
So
small,
whether
very
it
small,
could fall
very
into
small.
that category is the other thing.
Usually Sjogren's and HIV positive, when you
Yes.
get, he's not retroviral positive.
Okay.
So my question on this case, Lakshmi and Prahlad, I really need your thoughts here. Should I proceed to a VATS lung biopsy? And if I do, then from which part of the lung? Or should I just give him MMF? He has hardly any symptoms, or should I monitor without treatment? Lakshmi?
Yeah, biopsy, I think yes. Left lower lobe did show some increase or ground glass opacities. So left lower lobe is one we can consider for biopsy.
You'd also do VATS, Lakshmi?
Yeah, I'll do cryobiopsy, sir.
Okay, you're a high volume center for cryo, yeah. Okay. Right. So
And
left lobe, okay.
and then secondly, mycophenolate, yes, with functional monitoring, or maybe a trial of steroid before mycophenolate to see whether there is any improvement or not. If there is
After the
improvement
biopsy.
with trial of steroids, yeah. So if not for biopsy or after biopsy confirmation, trial of steroids and see improvement over say 4 to 8 weeks. And if that is there, then maybe come down on dose of steroids and maintain with mycophenolate.
So you would not do monitoring without treatment?
Monitoring without treatment has already been done. Historically, it is available to us and it shows some progression. 22 to 25, there is some progression.
Yeah.
And on both occasions, there is impairment on spirometry,
Correct.
even if he is asymptomatic.
Prahlad?
I think your history is such a strong that your hypersensitive pneumonia diagnosis is on history and scan. Okay, and you have that Pigeon's.
Yeah.
We have sufficient, you can say, evidence to say this is HP. Okay, and I would like to put him on a small dose of prednisolone and mycophenolate together and continue mycophenolate and reduce the steroid.
Why would you give dual immunosuppression, Prahlad? He has no symptoms.
No, but generally I do is 10 milligram BD of prednisolone for 7 days along with mycophenolate. It takes time. Though he has no symptoms, he has a disease inside. His cyst formation is happening. Cyst indicate.
No, I was just thinking we don't have the results of the MycoHype study, which Prakhar is part of. And do you think we should give dual immunosuppression if he was not agreeing to a biopsy here, or just?
The disease is very extensive. This is what I could see everywhere. And if you see if you have previous experience of hypersensitive pneumonia, these things are seen and they are all progress to fibrosis later.
But you don't want to give him a trial of removing him from the antigen and just.
Of course, that's a thing which we are.
So
you've done it also, but
no. So he's fixing the dam. Now only we have got all this done. So I think now he's going to look at antigen avoidance. He's put a complaint to the building society that this guy's feeding pigeons on the terrace. He's fixing his ACs. So that's all started now. All that has begun now, Prahlad. So I'm just wondering, would you do a biopsy, Prahlad, or would you do a BAL, or if you say this is HP, is it moderate or high confidence? Because you can't call it high confidence without a BAL.
soft centrilobular nodules which are there distributed. I don't think any other differential we can think about. That way, there are many differential diagnoses for this patient. Okay. But HP with the background history, what you have given in so depth. Okay.
So moderate confidence diagnosis and probably do a BAL to make it high confidence.
BAL can give us a.
Yeah, that would make it a high confidence, doing a BAL.
Yep.
If we can get that BAL done well, that also sometimes is a challenge for us. So I think that we will do. And Aparna, would you agree with Lakshmi on the left lower lobe if I had to proceed to VATS here?
Sir, it's diffusely abnormal actually everywhere. It's equally abnormal.
Okay. I know they say to avoid the lingula usually in a VATS biopsy. So I think I will tell the surgeon to do left lower lobe, from 2 segments. And if you did
what is your differential diagnosis? Suppose this is not.
Mine is HP. It's HP or Sjogren's. These are the 2 diagnoses. So I just was, and he's a young guy.
Sjogren's present without your this thing, Mithun?
Sjogren, in this case, Schirmer is negative, ANA is negative, 30% can be ANA negative, anti-SSA negative, but without dryness, it's extremely difficult. And they have also worked up for Sjogren. They have done an ultrasound of the parotid. Everything is normal. And it's a male patient, no?
Yeah.
In a male, Sjogren is extremely rare. Therefore, Sjogren is less likely.
So moderate confidence for HP, probably do a BAL then, I think. And I think we can avoid a biopsy then based on what Lakshmi and Prahlad are saying. If the BAL was showing a lymphocytosis, give a steroid trial. Prahlad?
Yes.
Yeah.
BAL will really help. It will add on your diagnosis.
In Mumbai, which is a good center to do BAL, Prahlad?
My center.
Okay, I'll send him to you for a BAL.
That's the best way to say that. Wow.
Of course, like what happened is one of my students were given this topic, but I told you Sujit long back.
Yes.
And I found it's a fantastic outcome of that study. We improved our BAL techniques. Our microbiology.
So you've mastered the BAL. See, yes, I was looking through the ATS statement on diagnosis of HP, and I realized that short of a biopsy, nothing gives you high confidence except BAL, coupled with all the symptoms, So if you look at that one box where the BAL lymphocytosis is there, plus all that I gave you, it could it could avoid a biopsy. So I will send him to you for a BAL.
CD4, CD8 really helps here.
Yes, and I'll send my resident also to learn the technique with you so that we can do it in the future.
Okay.
No, I don't want to say like that, but just the topic came, I thought.
No.
It's important. No, it's important because we all got to get better.
Everybody does. The BAL is not the bronchoscopist technique is not that important. It's important is the cytology person who is
processing. Sample processing.
And then KEM when we're there, that how much time it takes to process the BAL.
Yes, I remember. So you've mastered that. If you're on top of that, then I'm fine. Super.
Okay.
Great. Thank you.
Yeah, thank you. Thank you all. It was great today because we almost started 10 minutes late and still we finished by 6:20. So we are on our usual time. The next meeting will be on 18th April. It's supposed to be Good Friday. I believe it is a holiday in my calendar, but we will be on time at 5 o'clock. See you on 18th. Thank you.
Thank you.
Thank you. Bye.
Are we offline?
Are we offline, Manish? Manish, ho kya wahan pe aap? I don't know. What happened, sir?
It's okay. No, that last time's patient wanted me to put in.
Yeah, offline.
Last time's patient was had the cardiac MRI done. He was asking whether we could include him today, but Athol wasn't there.